Hello everyone. In this series of gynecology, today we will be discussing about an important topic that is pelvic inflammatory disease. So, so the pelvic inflammatory disease is it is the infection and inflammation of the upper genital tract organs, typically involving the organs like uterus, fallopian tube, ovaries, pelvic peritoneum, and surrounding tissues, also known as parametrium. And each of the inflammation of these organs have their specific name. Like the inflammation of uterus is called endometritis, especially the endometritis, salpingitis, ophoritis, peritonitis, and parametritis. So, pelvic inflammatory disease includes the spectrum of infection and inflammation of this upper genital tract infection. And especially, you have to note that the cervicitis and vaginitis is not included in pelvic inflammatory disease. We start from uterus and we end in parametrium. So, basically, the PID is attributed to the ascending spread of microorganism from cervico-vaginal canal to contiguous pelvic structure, and the clinical syndrome is and this clinical syndrome is not related to pregnancy and surgery. This is not related to pregnancy and surgery, and as we have already said, cervicitis and vaginitis are not included in pelvic inflammatory disease. So we will talk about epidemiology in very short. So what we can see that despite we have better understanding of etiology, pathogenesis, and even the improved diagnostic tool such as ultrasound, laparoscopic, and even with the arising of a wide range of antimicrobial, this pelvic inflammatory disease is still a very health hazard. It's a health hazard in both in developing as well as developed country, and due to that there is rise in the pelvic inflammatory disease. There has been rise in the pelvic inflammatory disease due to rise in STD, sexually transmitted disease, and the readily availability of contraceptive together with the people's increasing permissive attitude towards sexual intercourse has resulted in the incidence of STD. So what we can see is that around 85% of pelvic inflammatory disease have the spontaneous infection, especially in the sexually active female of reproductive age, whereas in 15% of the case it follows through after the various procedures like endometrial biopsy, uterine curettage, insertion of IUD, and stereosalpingography. Due to this iatrogenic condition, around 15% of pelvic inflammatory disease result, and around we can see that around two-thirds of the case of the PID is present in the women with less than 25 years of age. And as we have said, PID has been the major problem currently in the major problem in the reproductive health of young women, and PID can be asymptomatic as well as subclinical. So that was about if it's a short description on epidemiology of PID. And talking about risk factor, we can see that the PID is more common in the sexually active teenager and the women with less than a younger age population, and the women with multiple sexual partners. And if there is absence of any contraceptive pill use, then that lead to PID. Absence of contraceptive pill is a risk factor for PID. The previous history of acute PID is a risk factor, and the IUD user is an important risk factor for PID. But it should be noted that the hormone containing IUD like LNG, IUS are not the risk factor for PID. And the lower socioeconomic status and the husband or sexual partner with STI and urethritis are more risk factor for the woman. So if husband or sexual partner has STI or urethritis, then that is risk factor for women, and that genetic predisposition is another factor. So besides this factor, we have some protective factor as well. Protective factor includes the contraceptive practice, especially the barrier methods like condom, diaphragm with spermicide. They are protective, and the oral steroidal contraceptive has the preventive aspect, as they produce thick mucus plug and they prevent ascent of sperm and bacterial penetration. Also, it decreases the duration of menstruation and creates shorter interval of bacterial colonization of the upper tract. And also, next protective factor is monogamy or partner wed vasectomy is another protective factor. The pregnancy is another protective factor, menopause is another protective factor, and vaccination, hepatitis B and hepatitis HPV vaccination is another part. And we have the post-coital washing, urethra, genital tract, genital skin, post-coital washing is another protective factor for the PID. Now we will see in short about the microbiology part of the PID. The PID is usually a polymicrobial infection caused by the different microorganisms ascending upstairs from the downstairs, from up to down, and the primary organism are the sexually transmitted infection, like approximately like in 30% of cases it is due to Neisseria gonorrhoeae. In another 30% it is due to Chlamydia trachomatis, and in 10% case it is due to Mycoplasma hominis. And the secondary organism normally found in vagina are almost always associated with PID sooner or later, and they are some aerobic infects organism like Escherichia coli, group B streptococci, Staphylococcus aureus, and non-hemolytic streptococcus aerobic, and anaerobic organisms like Bacteroides species like Bacteroides fragilis or BBS, Post-streptococcus, Peptostreptococcus or Peptococcus. These are the secondary organisms. And mode of affection is the classical concept is that the gonococcus ascend up to affect the fallopian tube through the mucosal continuity and contiguity. This ascent is facilitated by the sexually transmitted vectors such as sperm and trichomonas. Sperm and trichomonas serve as a vector for the transmission of the infection, and the reflux of menstrual blood along with gonococci into the fallopian tube is also another possibility. And in the Mycoplasma hominis probably spread across the parametrium to affect the fallopian tube. And the lymphatic, the secondary organism probably affect the tube through lymphatic. And rarely the organism may affect the fallopian tube directly. Really, the gut microflora affect that. And the pathology, talking about pathology, we will discuss this in very short. So involvement of the tube is almost always bilateral, and usually the following menses due to loss of genital defense. First pathological process is initiated primarily in the endosalpinx, and that is innermost part of the fallopian tube. In the endosalpinx, there is gross destruction of epithelial cell, there is cilia microvilli, and there is in severe reaction. Almost all layer of the fallopian tube are involved, and all those they produce acute inflammatory reaction. They become edematous, hyperemic. The exfoliated cell along with exudate they pour into a lumen of the tube. They agglutinate the mucosal fluid, and that result in the closure of abdominal ostium. Due to pathological process, due to exudate and the plug, they close the abdominal ostium, and uterine end is also closed. Abdominal ostium is usually closed due to the indrawing of edematous femurae and by the inflammatory adhesion. First of all, okay, I will show by diagram. So this is abdominal ostium, and this is abdominal ostium is closed by indrawing of edematous femurae and by inflammatory adhesions. The uterine end is closed. The uterine end is closed due to by congestion, and the closure of both this uterine ostium and the abdominal ostium causes the exudate to settle down here in the they collect here the watery fluid, and that causes hydrosalpinx. It is watery producing hydrosalpinx, or it may has the pus containing spiosalpinx. Hydrosalpinx when there is the exudate is watery, or piosalpinx when there is exudate is filled with pus. There will be exudate inside the tube after the closure of this ostium, and occasionally the exudate may pour into the pelvic peritoneum. They may pour into the pelvic peritoneum through the abdominal ostium, and they can produce pelvic abscess, or they may produce the ovarian abscess, and finally that result in tubo-ovarian abscess. So that was the pathology of PID. How the abscess is formed, how process is initiated, how hydrosalpinx is formed, and how the final result like pelvic peritonitis, pelvic abscess, tubo-ovarian abscess is formed. Now we will talk about most important part of this video, that is clinical feature of this pelvic inflammatory disease. The patient with acute pelvic inflammatory disease present with wide range of non-specific clinical symptoms. The symptoms usually appear at the time and immediately after the menstruation, and there may be various symptoms such as bilateral lower abdominal and pelvic pain that is dull in nature. The onset is more rapid and acute in gonococcal infection than in chlamydia infection. In gonococcal, there is pain within the 3 days of infection, and in chlamydia within 1 week of infection. And fever, there is fever, latitude, that is weakness and headache. There may be irregular and excessive vaginal bleeding due to associated endometritis. There may be abnormal vaginal discharge that may be purulent and or copious. There may be nausea and vomiting, and there may be dyspareunia, painful. Coital act is difficult or painful. The pain and discomfort is there in right hypochondriac region due to the concomitant perihepatitis. Fish-Hogg-Curtis syndrome. Fish-Hogg-Curtis syndrome means there is due to perihepatitis, there is pain and discomfort in right hypochondria, and the liver is involved due to transperitoneal or vascular dissemination of either gonococcus and chlamydial infection. And also it may be slightly noted that in laparoscopic examination of Fish-Hogg-Curtis syndrome, it reveals inflamed liver capsule with classic violin string adhesion. This may be important for MCQ exam. The violin string adhesion is found in this perihepatitis, this Fish-Hogg-Curtis syndrome in ultrasound. In laparoscopic examination. And there may be signs. The patient may present with sign with temperature greater than 38.3 degrees Celsius, or we can generally say 38 degrees Celsius. In the upper abdominal palpation, it reveals tenderness in both lower quadrant. The liver may be enlarged. There may be perihepatitis. The liver may be enlarged and tender. The point vaginal examination reveals the abnormal vaginal discharge. It may be purulent. There is congested urethral meatus or opening of the Bartholin ducts through which pus may be seen escaping out under the pressure. And in perispiculum examination, we can find a congested cervix and purulent discharge from the canal. And on bimanual examination, results in bilateral tenderness on fornix palpation, which increases more with the movement of cervix. Cervical motion, there is especially this, we have to remember this point, there is cervical motion tenderness and adnexal tenderness on bimanual examination. So that was about sign and symptoms, and let's revise it again in short. Pain, bilateral lower abdominal pain and pelvic pain, fever, lassitude, headache, irregular menstrual bleeding, excessive menstrual bleeding, abnormal vaginal discharge, nausea and vomiting, dyspareunia, and that's all. cervical motion tenderness, adnexal tenderness in bimanual examination, and tenderness in abdominal examination. There is tenderness in both lower quadrant. So that was about sign and symptoms of PID. Now we will move on to the next part, that is investigation. The investigation focus on firstly the identification of organism. The material, the sample are collected from various available sources, like we may collect discharge from urethra or Bartholin's gland, from the cervical canal, or we may collect the pus from the fallopian tube through laparoscopy or laparotomy. The material is so collected is subjected to gram stain and the gram stain and culture, and the finding of gram negative diplococci is suggestive of gonococcal infection. Except in very highly sophisticated institution, the detection of chlamydia trachomatis is difficult, and as the process of investigation is not specific and it's time consuming, the treatment of for chlamydia trachomatis should be started from the clinical diagnosis only. And the positive gram stain smear from endocervical mucus is non-specific, and the negative smear doesn't rule out upper genital tract infection. So the first part is identification of organism. Second part is about leukocytosis. The leukocyte count crosses more than 10,000 per cubic mm. There is elevated ESR level greater than 15 mm per hour, and the result correlate with the severity of inflammatory reaction in the fallopian tube as seen in laparoscopy. The serological tests for syphilis should be carried out for partners in all cases. And on the laparoscopy is considered the gold standard for the diagnosis, and it is most reliable aid to support the clinical diagnosis, but it might not be feasible in all cases, and it is reserved only in those cases where in which the differential diagnosis including salpingitis, appendicitis, or ectopic pregnancy, and the non-responding pelvic pain mostly need laparoscopic evaluation. In laparoscopic finding, we can get some tube edema. In mild infection, we get tube edema, erythema. In moderate, there may be moderate infection. There may be gross purulent discharge. In severe infection, there may be pyosulfings or abscess may form. So that was about laparoscopy. Nextly, we can do sonography, but it is of limited value. And we can also do MRI. MRI might be useful, and we can finally do the choledosynthesis, that is aspiration of peritoneal fluid from peritoneal fluid, and its wide WBC count is noted. It exceeds 30,000 per ml. So, and we have to do investigation also in male partner. And in male partner, we have to take the smear and culture from urethral secretion. The diagnosis of PID is made by the CDC criteria. So we will see what does the CDC say. We will see that. According to CDC criteria, the minimum criterion for the diagnosis of acute PID is lower abdominal tenderness, the adnexal tenderness, or cervical motion tenderness. The adnexal tenderness and cervical motion tenderness is found in bimanual examination. And an additional criteria for diagnosing pelvic inflammatory disease is oral temperature greater than 38 degrees Celsius. There is fever. The mucopurulent cervical or vaginal discharge. Abundant WBC and saline microscopy of cervical secretion. The raised CRP, elevated ESR, and the laboratory documentation of positive cervical infection with gonorrhea or chlamydia trachomatis. And the definitive criteria are histopathologic evidence of endometritis on biopsy, imaging studies such as transvaginal sonography and MRI showing evidence of thickened fluid-filled tubes with or without free pelvic fluid or tubo-ovarian complex. The laparoscopy evidence of pelvic inflammatory disease. Although initial treatment can be made before bacterial diagnosis of chlamydia trachomatis and Neisseria gonorrhea infection, such diagnosis emphasizes the need to treat sex partner. So that was our definitive criteria. and just let's revise laparoscopic finding too. As we have already said, that in mild infection there is tube or erythema, no spontaneous urinary discharge. So you can just grossly see it, and that was all. Now talking about differential diagnosis of PID, we have appendicitis as a differential diagnosis. Second one, disturbed ectopic pregnancy. These two must be ruled out at any cost, and there may be endometriosis, torsion of ovarian pedicle, hemorrhage or rupture of ovarian cyst, diverticulitis, and UTI. These are the differential diagnosis for in PID. Now talking about treatment. So before treatment, let's discuss about complication of PID also. So the complication of PID are like immediate complication can be just pelvic peritonitis or even generalized peritonitis. Now there may be septicemia that may produce arthritis and myocarditis, and there may be late complication of PID like dyspareunia, infertility, and the chronic pelvic inflammation, and there may be formation of adhesion, hydrosalpinx, pyosalpinx, or tubo-ovarian abscess. There is chronic pelvic pain and ill health. There is increased risk for ectopic pregnancy. So that was about complication. Now in treatment we have the two modalities of treatment: preventive and curative. For the prevention of PID, we can do the community-based approach to increase public health awareness and prevention of STIs with the knowledge of healthy and safer sex, liberal use of contraceptive, and routine screening in high-risk population. And for curative, there are definitive principle of therapy, that is to control infection, prevent infertility and late sequelae, prevent reinfection, and follow-up examination in women within 48 to 72 hours. And in the outpatient department, apart from adequate rest and analgesic, antibiotic are to be prescribed even before the microbiological report is available. So we should not wait for the microbiological report, but we should start antibiotic as soon as possible. And because infection is polymicrobial in nature, instead of single antibiotic, we have to do the combination of antibiotics. And the antimicrobial coverage should cover the infection like Neisseria gonorrhoeae, chlamydia trachomatis, streptococcus E. coli, and anaerobes. And the antibiotic which cover all this infection are usually this group of antibiotic. We can use the ceftriaxone 250 mg intramuscular single dose, or alternative to that is cefoxitin 2 gram intramuscular single dose, and probenecid, and injection cefotaxime. So one homework for you guys. So just mention in which generation does this cephalosporin belong: ceftriaxone, cefoxitin, and cefotaxime. Just write in the comment section. And the doxycycline, we have 100 mg PO per oral for 2 times a day for 14 days, with or without metronidazole 500 mg oral twice a day for 14 days. So the treatment is ceftriaxone 250 mg intramuscular single dose and doxycycline 100 mg per PO BD for 14 days, with or without metronidazole. Ceftriaxone, doxycycline, and metronidazole. Please remember these 3 drugs. So, and next thing is inpatient of therapy. Inpatient therapy. What are the indication for hospitalization? We will not hospitalize all patients of PID. So what are the specific points for which we have to hospitalize the patient? We may hospitalize the PID patient in suspected tubo-ovarian abscess, and if there is illness is very severe and vomiting and temperature is more than 30 degrees Celsius, and if there is uncertain diagnosis where surgical emergency is there, surgical emergency like appendicitis cannot be excluded, and unresponsive to outpatient therapy for 48 hours, and intolerance to outpatient oral antibiotics, and coexisting pregnancies, and patient is known to have HIV infection. In that condition, we have to hospitalize the patient. And the treatment will be adequate rest, oral feeding is restricted, the patient the dehydration and Acidosis are to be corrected by IV fluid. In the inpatient antibiotic regimen include the parenteral regimen A that contains cefoxitin plus doxycycline. The parenteral regimen B contains clindamycin plus gentamicin. Cefoxitin through IV every 6 hourly or doxycycline 100 mg POPD for 14 days. An alternative can be ampicillin sulbactam plus doxycycline. So these are about inpatient therapy. And the indication of surgery are comparatively less. The indication may be the generalized peritonitis, pelvic abscess, tubo-ovarian abscess, which doesn't respond to antibiotic, and if there is rupture of abscess, and if there is life-threatening injury, life-threatening infection, then we may consider for surgery. And to prevent reinfection, the following formalities are to be rigidly followed, like educating the patient to avoid reinfection and potential hazard of it. Patient should be warned against multiple sexual partners, to use condom. Sexual partner and our partners are to be traced, and they should be properly investigated to find out organism, and they should be follow up. The repeated smear and culture from the discharge are to be done 7 days following the full course of treatment. The tests are to be repeated following each menstrual period until it becomes negative for 3 consecutive reports when the patient is declared cured. Until she is cured, her sexual partner has to be treated and cured. The patient must be prohibited from intercourse until the infection is treated. So that was about follow-up and the counseling part we have to give for the patient. So that was all about PID. And so for lastly, we may consider some discussing about 3 important differential diagnosis of acute salpingitis, that is PID. These 3 conditions we have to differentiate this. One is acute salpingitis, that is in PID, acute appendicitis, and disturbed ectopic. These 3 are differential diagnosis. The difference between these are acute lower abdominal pain on both sides in acute salpingitis. There is pain start on near the umbilicus but settle in the right iliac fossa. And in disturbed ectopic, there is lower abdominal pain on one side. In amenorrhea and PB, amenorrhea and bleeding PB are present in disturbed ectopic but not in these 2 conditions. The GI symptoms like nausea, vomiting are present in acute salpingitis and acute appendicitis but not in disturbed ectopic. The general look is toxic in acute appendicitis. The face is flushed in acute salpingitis and pale in disturbed ectopic. The tongue has no significant change in acute salpingitis, for the tongue is dry in acute appendicitis, whereas tongue is pale in disturbed ectopic. Temperature is more raised in acute salpingitis, slightly raised in acute appendicitis, but not raised in disturbed ectopic. Tenderness is tenderness on lower abdominal on both sides. McBurney point may have muscle guard. The lower abdomen more on one side. Per vaginal examination reveals tenderness on both fornix. A mass may be felt, or tenderness on right fornix and high up. Pain may be through one fornix extending up to pouch of Douglas. And sonography, TB transvaginal ultrasonography shows edematous tube. Edematous appendix may be seen, and the empty urine cavity referred to POD. So that was about differential diagnosis of PID. Thank you. So that was all about PID. So next time we will come up with some new topic in obstetric and gynecology. Thank you. Till then, keep revising, and please leave the feedback in the comment section so that I can improve the things in next video, and let me know if you need any videos on some other topic of obstetric and gynecology or any topic in medicine. Thank you.